Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Thank you for you guys for coming in tonight, sharing this scientific event. And thank you for Amgen for making this invitation for all of you to be here. And thanks for He's a professor of cardiology in University of Montreal. He was the past president of the Canadian Interventional Cardiology. He's a known figure in the research in Canada, especially in interventional cardiology. We want to talk today about important concepts in aggressive early use of the PCSK9 in acute coronary syndrome, the data, and how it's important, and what data we have, and how it's different from the stepwise approach. Without further delay, I would like to invite Dr. Mansour to start. Hi, Dr. Mansour, to start the presentation, and we are eager also to hear what you are going to say to us tonight. Thank you.
Thank you very much for that kind invitation. It's a real pleasure and privilege for me to share this moment with you guys. And I would love to have as much as interaction we can have at the end of the presentation, or even during the presentation. It's up to you. So the task of today is to present on an updates on lipid management in 2026, and how can we prioritize treatment acceleration of lipids in high-risk patients. So I'm Samer Mansour. I'm a cardiologist, interventional cardiologist, and clinical researcher in Montreal University Hospital Center. For tonight, we have few objectives. So I would love to present recent advances in the treatment of lipid metabolism disorders, explore the clinical data surrounding a complementary approach in reducing cardiovascular risk, discuss new clinical guidelines and their impact on daily practice, identify current challenges and future perspective in the management of this epidemia. So as we all know from different cohort, there is classical risk factors that predispose to development of atherosclerotic cardiovascular disease. This is an example of those cohorts. This is the InterHeart, where we identified 9 risk factors that accounted for more than 90% of population attributable risk in developing heart disease. And when we look what was the most frequent risk factors that we encountered in patients who developed myocardial infarction during the period of follow-up, it was abnormal lipid profile, as you can see it here, by a high ratio of ApoB over ApoA1 that was encountered in more than half of the population as compared to other classical risk factors that we know. We all know that the cumulative LDL exposure increases the plaque burden and increases the lifetime risk of having atherosclerotic cardiovascular disease events. When you look to this slide and you look to the left panel and you see patients that will be increasing in age and getting older and older. And as they get older, the cholesterol can get increased. And as the cholesterol increased with age, that will increase the atherosclerotic plaque burden, and that will increase in parallel the rate of future major adverse cardiovascular events. In the opposite, and when you look to the right side panel on this slide, you will see that lowering the LDL will improve and will reduce the risk of atherosclerotic cardiovascular events in the future, when you see that the highest level is associated with the highest risk. Even if you go older and older in age, but you lower your LDL, you will be significantly lowering the risk of atherosclerotic cardiovascular future events. We know that the treatment of LDL reduction help to reduce the major cardiovascular events. And there is some difference between primary and secondary prevention that I will be mentioning to you. Here I will present a meta-analysis that was performed and published in Atherosclerosis 2 years ago in 2024, where we recruited data from 1966 to January 2023, coming from 60 randomized clinical trials, more than 400,000 of patients. What we noticed that every decrease by 1 millimole of per liter of cholesterol LDL, it is associated with 22 reduction in the major vascular events. But please bear with me and look to the reduction in primary prevention. So the relative risk reduction per 1 millimole per liter of LDL cholesterol lowering significantly decreased by increasing with increasing age in primary prevention. So the older you are in primary prevention, the better you will get a reduction of your future cardiovascular events when you reduce your cholesterol LDL by 1 millimole of liter. However, when you are in a secondary prevention, you already had an event, age doesn't matter. Those patients all deserve the cholesterol lowering, and every 1 millimole of cholesterol lowering will significantly reduce the future cardiovascular events on those patients. However, and unfortunately, in the real practice, we still see a lot of patients that they are not treated for their cholesterol, mainly when we go looking what's going on with in the primary care, when patients are in contact with the first line therapist, the generalist or family doctor. We conducted in Canada between January 2018 and 2019 a Canadian primary care sentinel surveillance network where we enrolled more than 770,000 of patients of adults aged at 40 years old or higher. 50% of those met the criteria for dyslipidemia. So half of the population enrolled here deserved to be treated. When we looked on the treatment they received, unfortunately, we found that 68% of them, they were not receiving a lipid-lowering therapy, despite having a clear indication with a high Framingham risk score observed in 35% of them, and 28% of them having a cardiovascular disease that is already known. Even when you start treating those patients with a statin, the management is suboptimal. This is data coming from the province of Alberta in Canada, where we enrolled patients between 2011 and 2019. They are all diabetic, more than 330,000 of diabetic patients, adult patients that they were enrolled. Look and see that 12% of those patients, we did not find any lipid profile measured in those patients. They are diabetic. And when we started to treat those who have a dyslipidemia in the presence of diabetes, and we followed them up to 1 year, we noticed that the adherence rate was only at 66% of those patients. That means there is 1/3 of the patients, they started the therapy prescribed by the doctor, but in the coming months, they stopped the medication. And when you follow up those patients who are adherent to the therapy, still taking the medication, 31% failed to meet the LDL targets. We were not able to lower their LDL lower than 2 millimole per liter, which means that we treated, but the treatment was completely suboptimal. What that tell us? It tell us that there is a lot of work to do. There is a lot of inertia in the field, and there is a lot of education to be performed, either for the healthcare professionals or for the patients, or both of them. The image is not more beautiful in the United States of America. Here, I will present to you a registry of 5,000 patients with established atherosclerotic cardiovascular disease. We enrolled them between December 2016 and July 2018, and we followed those patients for 2 years. You notice that 32% met the LDL goal of 1.8, 15 had an LDL level less than 1.4, and 17% had their lipid-lowering therapy intensified. When you look over the 2 years, you will only notice that 11% did not have a lipid assessment. So they did not get their cholesterol checked, one patient over 10. and 21% they had only one lipid assessment during 2 years of follow-up. Again, same issue, inertia, lack of education. Still in Europe, 18 European countries, we collected data and to see if there is any gap between what is recommended by the European Society of Cardiology and what's happening in the real practice. This is a cross-sectional observational study of primary and secondary prevention. Patients receiving lipid-lowering therapy. Only 33% of patients achieved their LDL goal, even though almost 80% of them, they were receiving moderate or high intensity statin monotherapy. So what was lacking there? What we missed there, that we missed the adjunctive therapies over statin. It's like if the doctors, they prescribed the statin and they considered that they did the job. No, the job was not completed because there is a significant amount of those patients where they're not on target for their LDL control. And when you look how many of those they get ezetimibe or they get PCSK9 inhibitors, this is a small percentage, 9.2% for ezetimibe and 1.2% for PCSK9 inhibitors. Let me share with you this example from our cardiac intensive care unit. This is a real case admitted a couple of months ago to our cardiac intensive care unit. This is a 72 years old gentleman known to be obese, type 2 diabetes. The only medicine that he was taking, it was metformin at a dose of 500 milligram BID. You can obviously see on the screen his electrocardiogram showing ST elevation MI in the anterior leads. So this patient is admitted because of an anterior STEMI. We were able to go back in the medical records and to see if his GP prescribed a blood test for him. We found one that was done 3 months before his admission with this STEMI. And when we looked to the lipid profile, we saw that there is some abnormalities and no one took care of that. What I want you to do every time you look on a lipid profile, please look at the beginning on the triglycerides, because if the triglycerides are higher than 1.5, the calculation of the LDL that your lab will be giving to you is not accurate. So when the triglycerides are higher than 1.5, look to the non-HDL or look to the ApoB if you measure the ApoB. But usually the non-HDL, it's giving automatically by the lab. For this patient, as a diabetic patient before his admission with the ACS, the STEMI, his non-HDL should be lower than 2.6. And as you can see, his non-HDL is at 4.1. So his doctor did not add a statin, which is a basic therapy that he needs to get as a 72 years old diabetic patient. His HbA1c is a bit still high at 7.2, and we never found any urinary ratio of albumin and creatinine in his file that could justify renal preventive measurements by adding ACE inhibitors or angiotensin receptor blockers. Of course, we rushed this patient to the cath lab, and he had a mid-LAD occlusion, thrombotic occlusion, a TIMI0 that we opened. We stented with a one drug-eluted stent and restored normal epicardial perfusion in that LAD, and everyone is happy. The patient is feeling better. Yes, we are happy, but we are not so happy because it is only the beginning of the story for this patient. Look to the data of this Canadian international trial, the COMPLETE trial, for STEMI patients with multivessel disease. We randomized those patients to have a full revascularization. This is a blue line here, or culprit vessel only revascularization and keep all the rest for medical therapy. Please be aware that all those patients were receiving the optimal modern therapy. There were antiplatelets, statins, ezetimibe when requested, ACE inhibitors, beta blockers when requested. So we were giving them the optimal medical therapy of what we can. So look with me on the group of patients who get the full revascularization. Of course, this is a group of patients that is at with the lowest rate of events. But still, at 5 years, these patients have 10% of risk of dying from cardiovascular disease or suffering from a new myocardial infarction. And of course, that risk will be higher if you keep patients with multivessel disease without full revascularization. On top, you can see that if your patient has other comorbidities, such as polyvascular disease, heart failure, diabetes, or any renal impairment, that also will significantly increase the rates of future MACE in the coming years. This is the algorithm of secondary prevention we used in our cardiac intensive care unit. So all patients, they will get dual antiplatelet therapy, they will get lipid lowering. If they are statin naive, they will have atorva 80 or rosuva 40. We prescribe ACE inhibitors or beta blockers depending on the indication. If they have heart failure with reduced ejection fraction, we will adjust the medication to give them the guided medical optimal therapy as it is requested by guidelines. And if they are diabetic, we give them cardiac and renal preventive therapies such as SGLT2 inhibitors and agonists of GLP-1. But the statin you saw there, the atorva 80 or the rosiva 40, will not solve everything in those patients. The statin will fix 35% of the lipid abnormalities in your patients. There is two-thirds of your patients that they still have lipid abnormalities and they will cause future cardiovascular events. And the number one cause of that is that your cholesterol LDL is not at goal. You did not reduce significantly the LDL level on those patients. Of course, there is other reasons such as familiar hypercholesterolemia, elevated lipoprotein little a, elevated triglycerides level, or low level of HDL cholesterol. Still, the residents and other doctors asking when I need to do a lipid profile for this patient when this patient will be admitted to the cardiac intensive care unit. Do I need to do a lipid profile for these patients? So should it be done in the first 24 hours before his discharge anytime, or wait and do that after 1 month after you start the medication, or it doesn't matter? Anyway, we are giving high intensity statin at the maximum dose. Let's look to the guidelines. When you look to the European Society of Cardiology guidelines, they request to perform on day one a lipid profile on this patient. Why this is important? It is important for two reasons. Because it will identify the baseline LDL for this patient, if the patient's baseline LDL is at 3.8 or 4 or higher, we won't lose time. We will be starting the statin and we will be adding automatically in my hospital the ezetimibe for those patients. And if the patient will have an LDL at 5 or higher, this is highly suggestive or familiar hypercholesterolemia. And in that case, we will be performing screening in the family of the patients to treat other members of his family that may suffer from the same lipid abnormalities, and that will help to prevent future cardiovascular events on them. If the patient is statin naive, we start with the high intensity statin. If the patient is already on statin and if he's not on target, we consider adding ezetimibe or PCSK9 inhibitors while the patient is still with us in the cardiac intensive care unit. What should be the target? What should be the threshold that will push us to intensify the lipid lowering? Is it the 1.4? Is it the 1.8? Is it 2? Or it's only 50% of reduction of the baseline LDL? So when we look to the European Society of Cardiology guidelines, this patient is considered a very high risk patient. This patient is admitted with a malignant presentation with a STEMI, and we should be aiming an LDL lower than 1.4 in this patient. And for those who attended the last American College of Cardiology meeting, maybe you saw the results of the Chinese trial that recruited almost 3,000 patients in secondary prevention after myocardial infarction, and they randomized them to get an LDL lower than 1.8 or LDL lower than 1.4. And of course, lowering the LDL lower than 1.4 was better than lowering the LDL lower than 1.8, and that was associated with a significant reduction of future MACE event in the group of patients where the LDL went lower than 1.4. When you look to our Canadian guidelines, Unfortunately, and I'm not very happy to show you that the recent edition of the Canadian guidelines is a 2021 one, but we are working on the update of the Canadian lipid guidelines, and that should be published by the end of 2026 or beginning of 2027. So what it is stated there that there is some clear-cut statin indicated conditions, and one of those conditions is patient with established atherosclerotic cardiovascular disease, like our patient who suffer from an ACS, and the patient with chronic coronary syndrome with documented coronary angiography disease, patient who suffered from stroke, TIA, patient with PAD, patient with abdominal aortic aneurysm. And there is a lot of those patients, maybe they don't have a clinical event. Those patients with carotid disease that you will observe if you do any neck ultrasound, or if you do an abdominal ultrasound for the patient and you see an abdominal aortic dilatation at 3.5, those patients are at the stage of secondary prevention and they should be treated with statin. And there is a lot of them circulating and at home, and they are not treated with a statin. And of course, in every medical contact, we enhance the message regarding health behavior modification, smoking cessation, diet, exercise at least 150 minutes per week. After the initiation of the statin, we look where we get the lipid profile. And please be aware that the statin that you will be prescribing today, in 2 weeks, the patient get the maximum effect of the statin. The same with the ezetimibe, the same with the PCSK9s. You do not need to wait 2, 3, 6 months to control the LDL. If you control the LDL in 3 to 4 weeks, and I will be showing the European and American guidelines regarding the LDL control when it should be performed, you will see what you will get with the prescribed dosage of statin. And if with that prescription, your patient is still at an LDL at 1.8 or higher, or non-HDL at 2.4 or higher, or an ApoB at 0.7 or higher, that your patient need an adjunctive therapy. Your patient need another drug. And it depends where we position this patient. If his LDL is somewhere between 1.8 and 2.2, our guidelines push us to start with ezetimibe. You can always start the PCSK9 inhibitor also as a second line. Here with our public system, the government won't allow us to use the PCSK9 as a second line. They always ask us to use the ezetimibe. Why in the Canadian guidelines they put that interval somewhere between 1.8 and 2.2, it is because of the amount of LDL reduction you can get by ezetimibe. You know that with ezetimibe 10 milligram once a day, you will get around 20% of reduction of your cholesterol LDL. So if your basal LDL is at 1.8 to 2.2 and you reduce it by 20%, you should bring the LDL lower than 2. And we know that, of course, the ezetimibe in the improved trial will help to reduce the future MACE rate during the years of follow-up. But a clear observation for you and for me when we look to those Kaplan-Meier's curves, that you can see that in the first 2-3 years, nothing happened. So when you invest with the ezetimibe, this is an investment not for the coming couple of years. This is an investment that will help to reduce the future cardiovascular events down the road. This is why it's so important to start intensifying that therapy as soon as you can. And you see that the curve started to separate at the end of year 3 and continue to separate up to 7 years of follow-up. You will tell me, is there a lot of patients that will end by having an LDL at 1.8 or higher? The answer is yes. Almost 40% of your patients on a maximum dose of intense statin will continue to have an LDL at 1.81 or higher. This is data from the PROVE trial, published now more than 20 years ago. All those patients were receiving Atorva 80. And you see that 37% of patients, despite being treated with Atorva 80, they continue to have an LDL higher than 1.8. And if you add ezetimibe to those patients, you will be lowering the LDL cholesterol by 20%, as we said. So you will end up by having at least one patient over five that receiving the combination of a statin and ezetimibe and still will continue to have an LDL higher than 1.8. And this 18-20% of patients deserve the third line therapy that is PCSK9 inhibitors. Look to this very important data coming from the Sweetheart Registry. So this is a huge number of patients discharged from the hospital after the diagnosis of myocardial infarction. In Sweden is a public system. Everything is in the is collected as an information. They have all demographic, they have all lab tests, they have all the medication that those patients are receiving during the hospitalization and after discharge. And they looked to the three groups of patients. The first group who get early ezetimibe added onto the statin. Second group, late ezetimibe addition. And third group, no ezetimibe addition that was performed in the 3 years of follow-up. Look to the Kaplan-Meier curves at the left side of the slide. This is the percentage of patients where the LDL went lower than 1.4 as requested by the European guidelines. You can see that when you add the ezetimibe early after discharge, mainly within the 3 months after discharge of your patient, you will get the highest rate of patients. 60% of patients will be having their LDL lower than 1.4. If you wait until you add it for several months or for years, of course, the rate of patients with a LDL on target is lowest. And of course, if you don't add it, this is the worst. And this is less than 40% of patients that they have their LDL lower than 1.4. But what is more important is what you see on the right side panel. Look to the MACE rates during the years of follow-up. And of course, adding the ezetimibe early will start an early prevention on those patients because you are lowering the LDL on them as compared on a late addition of ezetimibe. So the sooner you add a second line therapy to reduce the LDL, the better is to reduce significantly the future major cardiovascular events on those patients. The third possibility, if your patient has an LDL higher than 2.2 or ApoB higher than 0.8 or non-HDL higher than 2.9, in our guidelines, they consider PCSK9 as a second line, should be as a second line therapy. So PCSK9 inhibitors, as you know, the PCSK9 particles identification, this is a Canadian discovery. This is a discovery that was done by Dr. Nabil Saida in the Montreal Clinical Research Institute in Montreal downtown, who discovered those particles that may come and sit and block the LDL receptors at the surface of the liver cell. So as you know, those receptors, they have that job to capture the circulating LDL and bring that LDL within the cell. So if you have a lot of PCSK9 particles, you will reduce the amount of LDL receptors ready to perform that job. Using the antibodies that will block the PCSK9 particles will give a high number of LDL receptors ready to work and ready to capture the LDL. There is two types of PCSK9 inhibitors. There is the most commonly used one, the monoclonal antibody blocking plasma PCSK9. So if you look to the amount of plasma PCSK9, it is high. It will be blocked by the antibodies, and that will reduce the PCSK9 action in the atheroma plaque. The other class of PCSK9 is the siRNA blocking PCSK9 transcription that will block the production of PCSK9. So you will have less circulating PCSK9 and of course, reduced amount of PCSK9 in the atheroma. The beginning of the story of the impact and the benefit of the PCSK9 inhibitors in patients with secondary prevention started with the Fourier trial. This is the biggest trial. This is 27,500 patients with established atherosclerotic cardiovascular disease. prior MI, prior stroke, symptomatic PAD, that they were treated with high or moderate intensity statin therapy plus or minus ezetimibe. They all had either an LDL higher than 70 milligram per deciliter, so 1.8 millimole per liter, or non-HDL higher than 2.6, which is 100 milligram per deciliter. And they were randomized in two groups. One group that received the Repatha evolocumab subcutaneous injection of 140 milligram Q2 weeks, or the 420 monthly injection as compared to placebo. Those patients were followed approximately up to 2.2 years, the median period of follow-up, and the latest was for 3 years. When we look to the primary endpoint of the Fourier trial, that is a composite of cardiovascular mortality, MI, stroke, hospitalization for unstable angina, and revascularization, we can notice 15% relative risk reduction. But look to the Kaplan-Meier curves. It's very important to notice that the separation of the curves started within the first year, started after 6 months of therapy. So the investment here is very important with the reduction of the cholesterol LDL by the evolocumab, because you will be starting the reduction of future event within a year of treatment. When we look to the secondary objective endpoints, that is the combination of the cardiovascular mortality, MI, and stroke, we get also 20% of relative risk reduction. And again, the separation of the curve started within 1 year of treatment, which is very important to get an impact on the major cardiovascular events of those patients. It is important to note that there is some group of patients that they are at highest risk. Let's have a look on patients who had 2 prior MIs, or patients who had a recent MI, diabetic patients, patients with multivessel disease, or history of PAD. And every subgroup of those patients get an additional benefit by the addition of evolocumab as compared to placebo. And you can see that the relative risk of reduction was somewhere between 20 and 30%. The more sick you are, the more is the impact of the addition of evolocumab to reduce the major cardiovascular events. So if you look to the patients with a history of PAD, patients with multivessel, it is 30% of relative risk reduction. And look to the NNTs, it's you treat 28, 29 patients, and you reduce an event related to the cardiovascular mortality, MI, or stroke, as it is highlighted here. When you look to the Lp(a) concentration on those patients, so the impact of the medication is the same if your Lp(a) was lowest or highest than the median that was observed in the trial. And when your Lp(a) is less than 120, you still benefit from the therapy. And when your Lp(a) is higher than 120, you still benefit of the therapy. However, if your patient has a highest Lp(a), if the Lp(a) is at 120 or highest, here you are giving two gifts to your patient by prescribing the evolocumab. When you prescribe Repatha to a patient with high LDL and high Lp(a), you are working on both of them. We know that for the LDL by itself, you are offering him 60 to 65% of reduction of his LDL as compared to the baseline. And his Lp(a) will be reduced by 20 to 25% also. And this is the only available commercialized lipid-lowering therapy that is available in our hands that can lower the Lp(a) on those patients. And you know, as I know, that a high Lp(a) is associated with more future cardiovascular events on those patients. The data I showed you, it was for the first period of follow-up, maximum 3 years of follow-up. And we wanted to know what's going on if we extend the therapy in those patients. So what we did the Fourier open label extension. So we took a total of 6,600 patients that we followed up with for 5 years. So some of them were receiving the active evolocumab treatment during the randomization period, and another part of them, they were receiving the placebo. So those who were receiving the evolocumab will continue with the evolocumab, and those who were on placebo will start the evolocumab. And then we will compare between the two groups during that period of 5 years of extra follow-up. So this is an open label. So we know the patient know, the doctor know that his patient is receiving the evolocumab. Of course, you start the evolocumab, the patient that they were treated with the placebo, the LDL were around 2.2. First injection, boom, the LDL will go low. The LDL will be reduced by 60 to 65%. And you see that the median LDL that was observed in the Fourier only study was around 0.75 millimole per liter. We wanted to learn about the adverse events. Nothing happened. Look to the rate of adverse events, still low. Injection site reaction, less than 1%. Drug-related allergy, less than 1%. Muscle-related event, 1.2%. New onset diabetes, 1.2%. Hemorrhagic stroke, almost nothing, almost zero. So it is very reassuring. And this rate of events is low in both the group of patients who were on evolocumab or the group of patients who were on placebo and switch for receiving the evolocumab. When we look to the rate of events, and this is a very important message for you guys, when your patient was on placebo for the last couple of years and you put him on evolocumab, this patient is still at risk of future events. So you should not delay the initiation of the evolocumab because it is keeping him on placebo for a couple of years. And when you see the rate of events on those patients is still higher as compared to those who were on evolocumab and continued their evolocumab in the 5 years of extra period of follow-up. And that reduction was also, again, 15% of reduction related to the primary endpoint. And when we look to the secondary endpoint, we can see again the 20% of reduction. So what is that? What that is telling us? It is telling us that don't keep your patient on placebo. If you keep your patient on placebo for months and for years, you are keeping them on the blue line and you are reaching a highest level of cardiovascular events in the years to come. Try to have your patient on the red line. Like that, you are lowering the rate of future cardiovascular events on them. If your patient is younger or older than 75 years old, he will benefit from the switch to evolocumab. And of course, the oldest is the patient, the highest is the risk. And this is what you see on the blue line here curve, where you have the highest rate of events on patients that they were on placebo and they were older than 75 years old as compared to those they are older than 75, but they got the evolocumab at the beginning of the trial and they continued. Look to the rate of events on patients with multivessel disease. If you have a multivessel disease and you look to the primary efficacy endpoint, your rate of events is high. The same for the secondary efficacy endpoints. The rate of is high. So those patients you have with multivessel disease or patients with polyvascular disease, don't wait on them. Don't keep them on the highest rate and try to treat them as soon as you can. So this is the data related to the Fourier trial with evolocumab. As we know, there is a second agent that is the alirocumab that was tested in the group of patients after acute coronary syndrome, and we randomized almost 19,000 of patients who suffered from acute coronary syndrome within the first year after their discharge from the hospital. A group of them received the alirocumab and another group received the placebo, and we followed on them. When we look to the primary efficacy endpoint, that is a combo of the coronary heart disease deaths, non-fatal MI, ischemic stroke, unstable angina requiring hospitalization. So here, as you can see, there is no revascularization component that was added to the primary efficacy endpoint. We can notice also the same 15% of reduction of relative risk reduction, and that reduction will start to happen between the first and second year of therapy, as you noticed here on the separation of the Kaplan-Meier curves on this slide. When you stretch the follow-up of those patients up to 5 years, you will see that the patient treated with alirocumab will have a low rate of events, low rate of MACE. And they have a low rate of adverse events. The only observed highest rate was the injection site reaction that was observed in 2.5% of patients receiving the alirocumab as compared to placebo. The third agent is the inclisiran, which is the siARN that will block the production of the PCSK9. But here you can see that the level of reduction of the LDL is not as important as what you can get with the evolocumab. With the evolocumab, with Repatha, you can get 60 to 65% of reduction of your LDL as compared to the baseline before treatment. And here, the reduction of the LDL after one dose is around 40%. And after two doses, it will go near 50%, as you can see here. This is the level of PCSK9, and this is the level of LDL that will go somewhere between 40 and 50%, depending on the dose and the timing of the measurement. Of course, we do not have yet data on the cardiovascular outcomes. The Victorian PREVENT trial finished randomization. They are at the last steps of the monitoring of patients after randomization, and we expect to see the results of the trial by the end of this year or beginning of next year. Like we learned from the statins, some mechanistic teaching points, we wanted to understand how the PCSK9 inhibitors reduced the rate of events, how they reduce the rate of stroke, how they reduce the rate of MI and the rate of revascularization. So we went studying the atherosclerotic plaque at the level of the coronaries. Here in the GLAGO trial, we randomized almost 1,000 patients that they have evidence of coronary disease and they have a high LDL at 2.07 or higher, and they were randomized to receive the monthly dosage of Repatha 420 as compared to placebo. And the primary efficacy endpoint was to observe the nominal change in the plaque atherosclerotic volume from baseline as compared to week 78 after treatment as measured by IVUS. So all those patients, they get a coronary angiogram, they get IVUS performed, and after 78 weeks of treatments, we repeated the coronary angiogram and we repeated the IVUS. So what we noticed that the percentage of patients who get a plaque regression, that means that the plaque shrinked on itself, was higher when you added evolocumab in addition to statin. 2/3 of those patients get a plaque regression, and only on the statin-treated patient, only half of them get a plaque regression. There is no safety signals, and we noticed in the volume of the plaque, 1% of the volume of the plaque get reduced by the addition of evolocumab, which is very important and which is the same. If you remember, when we randomized patients to receive 40 milligram of rosuvastatin as compared to placebo, and we performed IVUS on those patients, we get the same thing. We get 1% of reduction on the plaque atherosclerotic volume, and here we have an extra 1% of reduction by adding the evolocumab. That regression and that reduction of the plaque volume explain why there is less plaque rupture, because the plaque get more stabilized and is less rich on fat, soft fat that predispose to the plaque ruptures. Another trial with the evolocumab was the Huygens trial. We recruited 164 adults with non-STEMI, and we treated them with evolocumab at the dose of 420 every month subcutaneously as compared to placebo. And the primary efficacy endpoint was to see the nominal change in the minimal fibrous cap thickness. You know that the highest is the fibrous cap, the thickest is the fibrous cap, the less is the risk of plaque rupture. When you have a thin fibrous cap, this plaque can rupture and can predispose to an acute event. And we wanted to compare it before treatment and after 50 weeks of treatment. And when we noticed in the trial that we were able to increase the percentage of patients that have the highest thickness of the fibrous cap while treated with evolocumab as compared to placebo. So the evolocumab in these two trials performed two things: regress the plaque get shrink on itself, and the cap of the plaque become more thick, and these two modification in the plaque will get that plaque more stable and less prone for plaque rupture, less prone for myocardial infarction and stroke in the future. Now, as we know, we need to treat our patients, and we start the treatment, we start the statin, we add it ezetimibe or not, when we need to control the LDL. We cannot keep them for months or for a year to control their LDL. What is in the guidelines? This is the European Society of Cardiology guidelines. It is requested to perform a lipid profile on week 4 to 6 after initiation of the first line therapy. And then we look to the LDL and we see if we are on the target. If not, we add on therapy, a second line or third line therapy to adjust the medication. And if we add a second line, we control on week 8 to 12. And if the patient is still at a high level of LDL, we can add PCSK9 inhibitors if they are on a maximal tolerated statin dose plus ezetimibe. This close monitoring and this quick optimization and intensification of the therapy, it is there in the European guidelines, and in the coming slides I will show you the updated American guidelines also. It's a class 1 level of evidence A. It's as robust as the impact of the medication and the protection you get the medication. You need to get it the soonest is the best. This is the update of the American College, American Heart Association about where to position your patient or how much you should lower LDL on your patients. If the patient is an ACS patient, it is good to lower the LDL somewhere between 1.4 and 1.8. And this is a class 2A for everyone, of course, less than 1.8. And we start with the statin. And if we didn't reach that level, we can add non-statin lipid lowering therapies that they are shown here: the ezetimibe, PCSK9 inhibitors, and bempedoic acids, mainly for those who are intolerant to statins. We can add the bempedoic acids that I will show you a couple of data on that molecule also. Again, the American College of Cardiology and the American Heart tell you that when your patient leave the hospital, you need to request a lipid profile on these patients between week 4 and 8. And you reassess the LDL with a fasting lipid panel. And this is again class A for the Americans. If your patient's LDL is at target, this is super, this is perfect. You continue with the same therapy. If not, if it remains high, you need to intensify the therapy. You need to add a second line or third line to intensify the therapy, and you control again between week 4 and 8 after your new prescriptions. This is the algorithm for patients very high risk, such as our patient. So start with high intensity tolerated statin. If you control and the LDL is still high, and here for this patient, for this very high risk patient, we aim to get lower than 1.4. You add ezetimibe or PCSK9, and both of them are class 1 indication to be added to this kind of patients. And if the patient is unable to tolerate or obtain or adhere to PCSK9, then we can switch to inclisiran. This is class 2A. And if the patient will remain is intolerant to statin or remain far from the target, we can add the bempedoic acid, and this is a class 2A indication to add the bempedoic acid in this kind. And this is the last thing that you can do following that algorithm. What if you don't do that? What if you keep your patient at a level highest than 1.4, 1.8 millimeter after myocardial infarction? So we look in the province of Alberta between April 2010 and April 2016 on every patient who get discharged from the hospital after myocardial infarction, and we look on their LDL levels. So we looked on what's happening on those patients that will remain with an LDL higher than 1.8, and the doctors did not perform any intensification of of the lipid treatment. Look to the rate of events of those patients. So this is 1 in 5 patients, 18% of patients had a primary cardiovascular event. What were those events? Cardiovascular death 8.7% and myocardial infarction 6.6%. This is real life. This is patients that they come to the doctor's office, they come to the hospital and get back, and their LDL is still higher than 1.8 and nothing is happening. Look what it will happen during the 3.4 years period of follow-up. Almost 9% of them will die, and another 6-7% of them will have a new myocardial infarction during that period of follow-up. I talked to you that for statin intolerant patients, there is the acid bempedoic acid that you can consider. When you look to the LDL synthesis in the liver, there is the ATP citrate lyase step where the bempedoic acid can block that step initially. This acid bempedoic will block through the enzyme of conversion at this level. And what is good that enzyme of conversion does not exist in the skeletal muscle. That means that patients will not suffer from myalgia. So for your patients with statin intolerance, that could be an option that you can consider. And in the CLEAR outcome trial, we randomized patients with statin intolerance that the majority of them received a very little dose of statin or no statin, so less than Rosuva 5, less than Atorva 10, and we randomized them. 3/4 of them were in secondary prevention, 1/4 diabetic with extra risk factors, and they get randomized on bempedoic acid at a dose of 180 per day as compared to placebo. And when we look on the 4 component of MACE, we get 13% of reduction. And when we look to the 3 component MACE, so cardiovascular mortality, MI, and stroke, we get 15% of reduction. And that was explained mainly by the reduction of the fatal and non-fatal MI and the reduction of coronary revascularization. The bempedoic acid by itself, it will lower your LDL by 23%. And if you take the combo containing the ezetimibe plus bempedoic acid, you will top your reduction of LDL to 38%. However, when you compare that reduction to what you get with the PCSK9 inhibitors, it is far from 60%. Of course, if you need to add it on to PCSK9 inhibitors, and here you have the maximum of what you get with a high intensity ezetimibe, bempedoic acid, and PCSK9, you can lower your LDL by 86% as compared to the baseline. So we have like another choice that we may add, and as you saw, it is integrated in the American Heart Association algorithm, mainly for statin intolerant patients. Here, another piece of information that I wanted to share with you. It is very important, and it's coming also from the Swede Heart Registry. This is a big number of patients with MI. They get discharged from the hospital. So more than 46,000 of patients in Sweden after myocardial infarction that they were followed. And we looked when we reached the non-HDL on target for them. You can ask me why they took the non-HDL. They took the non-HDL because I said some patients may have high triglycerides, so the LDL level is not very accurate. For the non-HDL, that will be accurate for everyone. And we know that for the non-HDL, following the European guidelines, it should be lower than 2.2. This is the target. If you get that target, this is the green line here, within 2 months, and you keep it sustained in the first year, this is the lowest rate of event that you can get in your patient. So this is the best. So treat early and stay on that treatment. You will reduce the future cardiovascular events by 20% on your patient. If you don't get it early, it will take time for you to get it. You will reduce the rate of events by 10%. If you get it early, but you don't maintain it, it's not sustained with time. Also, you will lose the benefit of that reduction, and it won't be higher than 10%. And if you don't do anything, this is the worst for your patient, of course. So the key message here again, and it's another piece of information that was published in the European Heart of Journal in 2024. Treat early, treat intense, and maintain that therapy on the long run. This is what would improve the therapy for your patient. And was what I said to my residents and my cardiology fellows, that with LDL reduction, lowest is the best. We had to use before that lower is better. Now we use the terminology lowest is the best. Even if your patient will get, when you prescribe statin, ezetimibe, and PCSK9 inhibitors, and you have an LDL that goes low to 0.5, 0.6, we tolerate it. We don't do anything for that patient. We don't stop the ezetimibe or reduce the PCSK9 or reduce the statin dose. The only time that we may stop the ezetimibe or reduce the statin dose if we get an LDL lower than 0.5 millimole per liter. Even when you look to the Fourier trial and you look to the stratum of LDL reduction in the actively treated patient, if you are somewhere between 1.4 and 1.8, you will get that risk. If you are between 1.4 and 1, your risk is lower. If you are between 1 and 0.5, your risk is lower. So this is why we say lowest is the best, because the lowest you take your LDL, the better is your prevention for the future cardiovascular events. The last couple of slides, I will be showing you some data related to the triglycerides. This is something that you get on the lipid profile, and this is something that is associated. This is a cohort from the Copenhagen cohort of patients, almost 100,000 of patients that they have high triglycerides, and we follow them. And those with high triglycerides, higher than 150 milligram per deciliter or 1.5 millimole per liter, they are at increased risk of myocardial infarction, ischemic heart disease, all-cause mortality, or ischemic stroke. So it's a good marker of future cardiovascular events on your patients. And as you know, up till now, neither fibrates or any other medicine that you use to treat triglycerides will help to reduce the major cardiovascular events. In our guidelines and in our practice, we don't use fibrates until the triglycerides will go higher than 10, and this is only to prevent pancreatitis that could be induced by the high triglyceride levels. So we have only one available medicine that we can use for those patients in secondary prevention or primary prevention when they are diabetic with other risk factors. It's the icodapant ethyl at a dose of 4 grams per day. And this is data coming from the REDUCE-IT trial, more than 8,000 of patients that were randomized to receive the icodapant ethyl at the dose of 4 grams per day as compared to placebo. And the patient had their triglycerides somewhere between 135 and 500 milligram per deciliter, and they have their LDL treatment optimized in the last 4 weeks before being recruited in the trial. When we look to the primary objective of the trial, which is a composite of the 5 components of cardiovascular mortality, MI, stroke, coronary revascularization, and stable angina, we get a 25% of reduction, and we can see that the effect of the treatment started after 1 year of treatment, and that was associated with a 24% of reduction in the actively treated group as compared to placebo. And when we look to the secondary objective of the trial, looking to cardiovascular mortality, MI, or stroke, we get another 26.5% of reduction. So this is the algorithm of the Canadian Cardiovascular Society. Patients with ASCVD, if they have triglycerides somewhere between 1.5 and 5.6, we consider icosapent ethyl on them. And if they have an LDL or ApoB or non-HDL higher than the target, we consider ezetimibe and PCSK9 inhibitors. And this is my last slide to show you the secondary prevention for persistent risk. Yes, statin are the first line, but if your LDL will stay higher than 1.5, you go to ezetimibe, you go to PCSK9. In our reality, as the majority of our patients are covered by the public system, the government will always ask us to add ezetimibe first. And if the patient will have an LDL higher than 1.5 or non-HDL higher than 2.4, then it is authorized to prescribe the PCSK9 inhibitors on them. And if the lipid, if the triglycerides are somewhere between 1.5 and 5.6, the IPE. For now, there is no drug for the inflammatory risk. There is controversial data with the colchicine. It's not part of our routine prescription. And if patients diabetic with HbA1c higher than 7%, we go with cardioprotective drugs such as SGLT2 inhibitors or agonist GLP-1. And for the thrombotic risk, after the period of dual antiplatelet therapy, if the patient has a polyvascular disease, we go with the rivaroxaban 2.5 in addition to aspirin. Or if there is no polyvascular disease, we continue either the aspirin, and now we are using more and more the clopidogrel based on host exam data. We are using more and more the Plavix as a single antiplatelet therapy on the long term. And for the blood pressure, we maintain those patients on a systolic blood pressure less than 120 following the SPRINT data, and it's part of our Canadian hypertension guidelines. So I will stop there, and I thank you honestly for your attention, and I'm very open to take your questions, your comments, your experience, and feel free to ask me any question or to share any comment or any experience. Thank you very much again.
Thank you. Thank you, Dr. Samer. Certainly, it was very high-fat lecture with a lot of.
It is a word, huh?
So now we have the floor is open for question. But before we start, let me discuss with you the concept of early triple therapy for acute coronary syndrome of the high-dose statins, ezetimibe, and PCSK9 on site, like what happened in acute statin use in the acute MI, versus the step therapy. Do we have in 2026 data to differentiate which way we will go, or still we are on the way?
So the data is the data that I showed to you regarding the impact on the early intensification. We do not have a kind of randomization except was what I said for the lowering regarding the threshold of intensification, the recent Chinese trial where they compared between 1.4 and 1.8, and to get to 1.4, they were on a rush by adding second and third line therapies. So there is no randomization between like stepwise, take 1 year of time to get to the target as compared to doing it and within a couple of months. However, when we look to the data that I showed you coming from registries and coming from the clinical trials, and when you see that the impact of the intensification of therapy is early, mainly when you use the PCSK9 inhibitors. So this is the reason why the guidelines in Europe and in the United States put it as a class 1 to get a control as soon as possible of the lipid profile and to intensify the therapy. And the most strong piece of information we have is coming from the Fourier only. Keeping your patience and taking your time for a stepwise, I see you in 3 months, I see you in 4 months, I add the ezetimibe, you pay attention to your diet, I control your cholesterol 3-4 months down the road. This is keeping your patient on the blue line I show you for placebo 4 months and years. And this is a clear demonstration that you are keeping your patient at a high risk of cardiovascular events.
I agree completely, but there's 2 important points I want to add. Well, number one, is, as you know, the mortality data benefits for reduction of the LDL. Not every way of reduction of LDL reduce mortality, i.e. we have data for ezetimibe, but it doesn't reduce mortality on its own. It has to be combined with statins. So yes, the reduction of the LDL is beneficial, but the way how we reduce it is also important. Anything in the floor? Any question?
Let me just add maybe one comment while you are moving to the people asking question regarding the mortality. The only piece of information we have related to the cardiovascular mortality is coming from the Fourier-Olley. When you look to the cardiovascular mortality reduction in Fourier-Olley, the patient that they were treated with evolocumab and you continue evolocumab in the coming 5 years of follow-up, you are reducing their cardiovascular mortality. And if you keep them on placebo for years and you jump to add the medication down the road after 2 years or 3 years, you keep them at a higher risk of cardiovascular mortality. It is when it is an add-on therapy, this is the only class of medication that was able to show in a long-term follow-up an impact on the cardiovascular mortality. And I agree with you, with ezetimibe, we don't have any signal on the cardiovascular mortality. It's more a signal related to the reduction of MIs that will happen down the road as we saw it together.
Yes.
تفضل دكتور.
In your opinion, which guideline you follow, the American or the European or the Canadian? And there is a major differences between all these guidelines. Also, we have here the Saudi Arabian guideline we are using also.
Absolutely. So this is a great question. To be honest, I follow the European guidelines because they have the update that is done almost every 2 years, and they captured all the new literature in these guidelines. The Americans they are doing the updates of their guidelines every 4 years. So there is some gaps sometimes with the new fresh data that is not integrated in the American guidelines. So more and more we are lowering the LDL in our patients in the daily practice lower than 1.4 as it is recommended in Europe. And I'm pretty sure in our coming Canadian guidelines that I hope they will be delivered before the end of the year, it will be less than 1.4 as it is in Europe right now.
Any other question in the floor? While people getting a question now, what do you have any new news about olpasiran and pelasiran in people who have high LPA and LDL below 55 after their index event?
Yes. So we participated in those trials, and we were part of centers who put patients in those trials after acute coronary syndrome, treated with optimal LDL, and they get randomized. The only thing that I can tell you that the medication is very well tolerated on those patients. We didn't saw any major side effects during the period of follow-up. But of course, the studies are not unblinded yet. So we are looking forward to see the results on the cardiovascular outcome.
Do you think it will be by the end 26 or early 27?
Early 27.
Oh, that's good.
Yeah.
Any other question?
So I have a question in the chat box here, if you allow me to read it.
Go ahead.
So what is the rate of statin discontinuation in your practice? We have a major issue with misinformation in social media against lipid-lowering therapies. Great question. And this is a challenge in every cardiologist clinic. I'm pretty sure that they come to you with a piece of the newspaper or one message on TikTok or in Instagram from Dr. Google they are bringing to you. We face the same here, and it's a matter of education. My only answer to the patients is they need to trust the data. And of course, they need to trust their doctor because we are the expert in the field, and you are the expert in the field, and you follow the guidelines. The guidelines are based on the evidence. And I tell to my patient, if there is a drug that we use where we know how it works, what is the impact of that drug? It is, of course, the statins. It has been more than 3 decades that we use them from now, and we know exactly what will happen to the atherosclerotic disease when you use these drugs. There is a lot of other drugs that we may prescribe to our patients, and we don't know exactly, and we don't have 3 decades history of using them. So the rate of discontinuation, we looked on that in the Canadian registry, and we saw that it could be close to 20% within the first 2 years in secondary prevention. So that was high. And this is why we created in our center what I call it a secondary prevention clinic. So after a patient discharged from the cardiac intensive care unit, we work in a very high volume center. So we have like at least 100,000 of visits to our cardiology department per year. We are a total of 31 cardiologists working in the center. So of course we cannot follow those patients by guidelines to get a lipid profile measured 4 to 8 weeks after discharge, intensify the therapy, get another 4 to 8 weeks another lipid profile. So this is why I created the secondary prevention clinic, and they are following the algorithms that you saw on my last slide here. But it is managed by nurse practitioners and or pharmacists. The patient will come with the lipid profile, and then they will be looking to the patient adherence of therapy. They spend time with patient to educate the patient, to explain the patient what is the aim of the therapy, and they check the values. They look to the cholesterol, LDL, triglycerides, smoking cessation, diabetes, hypertension, and they adjust the management of those risk factors. And that's happening in the first year after discharge. After that first year of discharge, it will be the job of the cardiologist continue following of them with the GP, with the family doctor. But what is crucial is to put them on the appropriate medication and to intensify the management of the risk factors in the first year after the follow-up. And the earliest is the best, as I showed you, and I shared the guidelines recommendation and the data we have in the literature.
Okay, now let me ask you my last question from my side is the concept of residual risk.
Yeah.
As you know, this is a concept which bothering the cardiologists in 2026 with maximum reduction of the LDL and still the LPA therapy coming in, the anti-inflammatory issue. There was a signal of increased pneumonia with colchicine. And this is back off us again from the anti-inflammatory medication. Where do you think the direction going in this reduction of the residual cardiovascular risk after LDL reduction?
So I think our next fight is with inflammation, as you said, and there is a lot of anti-interleukin 6 medication that we are studying right now. There is a new trial that is happening right now with Zilti, that is a Novo Nordisk medication. We are participating in that trial, and the mechanism of action is again the interleukin 6 to fight against the inflammation that is happening in the atherosclerotic plaque. And this is a complete different concept as compared to the data with the colchicine. As you know, we were a part of the Colcott trial. The Colcott is a Canadian initiative trial that showed some protective effect of the colchicine. And as you know, when you look to the European Society guidelines, it's a class 2B right now to add colchicine post-MI. And recently, in the last American Heart presentations, there is another Canadian trial that was presented by my colleague Sanjit Jolie from the McMaster University that showed a completely neutral effect of colchicine. No benefit of colchicine, even though they measured the CRP on those patients and they proved that the CRP is going low with the colchicine, but no effect on the MACE rate of those patients. So for now, we don't prescribe colchicine to our patients as a secondary prevention, and we are waiting for the coming trials to see if we will have a more benefit coming from the anti-interleukin 6 therapies.
Okay, at the end of this talk, I would like to thank you, Dr. Samir, and thanks our audience, and thanks Amgen for this scientific meeting, and looking forward to see you all, you guys, in another meeting. Thank you.
Thank you very much.
Thank you very much, Dr. Samir. There's a couple of questions in the box if you'd like to
Yeah,
answer them.
I will answer them right away.
Thank you so much.